And we are live, sir.
Yeah. So I think we can begin. So a very good evening to all the Pune IAP members and all the pediatricians who have joined this session. As we are all aware, the COVID second wave has struck us really badly, and we are getting a lot of pediatric patients as well in this situation as compared to the previous wave. So several of our members suggested that we have a update on the COVID situation, especially with respect to the pediatric COVID. And we also agreed to that suggestion, and we have arranged this webinar at a very short notice. At the outset, I would like to thank Tanu Singhal ma'am for accepting our invitation to be a part of this webinar as a faculty. Our other faculty, Dr. Yevle sir, Dr. Vijay Yevle from Navi Mumbai, unfortunately has had a small emergency in the family as far as the health of the family members is concerned. So he will not be able to come online right now, but subsequently sometime during the webinar, he'll join us and he'll be there to answer our questions as well. Because of this unforeseen change, actually, the topics have changed a little bit. We are not going to cover the vaccines as a separate talk. We may take some questions on that at the end if there are any. Otherwise, most of the topics would remain the same. I now request Dr. Deepak Mule to please take over and start the proceedings for today's webinar. Deepak, can you take over?
Yeah. Thank you. Thank you, Nathu sir. Good evening to all. As Nathu sir said, currently much needed topic we are going to discuss today. COVID and related queries will be discussed today in open forum in question answer session. Today we are going to talk. Our faculty are going to talk on applied virology, changing epidemiology, clinical manifestations, and updates in diagnosis and management. Our today's faculties are very well-known pediatricians. Dr. Tanu Singhal ma'am. She is a consultant pediatrics and infectious disease at Kokilaben Dhirubhai Ambani Hospital, Medical Research Institute, Mumbai. She is the advisor ICMR for antimicrobial stewardship. She is AB member of FISF, Fungal Infection Study Forum. She has many publications in national and international journals, along with 2 books and 20 book chapters. Another faculty is Dr. Vijay Yevle sir. He is a consultant and head Institute of Child Health at Apollo Hospital, Navi Mumbai. He is a past CIAP president in 2014. He is a chairperson for Asia Pacific Pediatric Association Task Force on antimicrobial resistance. He is a co-investigator WHO project on evaluation of typhoid conjugate vaccine. He is a member of expert committee on regulation of newer anti-tubercular drugs of India. As Nathu sir said earlier, Yevle sir will join as early as possible. Don't wasting much time. I will hand over to Tanu Singhal ma'am. Ma'am, please.
First of all, I'd like to thank all Pune IAP members for calling me, to give this presentation. And okay. So they are basically 2. Can you see my slides?
Yeah.
Yes, ma'am.
Yes, ma'am.
So basically, there are 2 parts of my presentation. The first part is more a virology type presentation where I'll just try to clarify a nomenclature of these SARS-CoV-2 viruses, the mutants which are there in circulation, etc. And the second part of my presentation is more practical because it talks about diagnosis and management of COVID-19 patients. So before I talk about about these viruses, let me clarify something about these terms. So we all know that viruses mutate regularly during replication. It's in their nature. And RNA viruses lack a proofreading mechanism, unlike the DNA viruses, and hence they make more errors during replication. Like you all know about influenza, it makes so many mutations that you need a new vaccine every year. And while the coronaviruses have one of the largest genomes amongst all the RNA viruses, and they have also some repairing mechanisms, enzymes, but they still mutate regularly when the force of transmission is high and when there is partial immunity present. And because of this property of the viruses, it leads to different clades or lineages of the virus. So basically, the virus which is there in circulation at this time is not the same which originated in Wuhan more than a year back. So you get different clades or lineages. Now, what happens is that these mutants that have transmission advantage are selected because when there are, let's say, some original virus in circulation and a mutant comes along, if that mutant virus is more easily transmissible amongst people, it outdominates the original strain. And these, if they are either multiple mutations or there is a significant single mutation in the virus, it leads to the development of a variant. So remember that all variant viruses are mutants, but all mutant viruses are not variant, because if it's a minor mutation, while it will lead to change in the genome of the virus, it is not going to really affect the characteristic of the virus. And when a variant virus has different phenotypic characteristics, like maybe it is more infectious, it has a higher R0, or if it is more lethal, it is co-termed a strain. So sometimes the term variant and the strain are used together or interchangeably. And how do we know about these mutants and clades, etc.? It is because of the, that all people who are sequencing the genome of the virus upload their genomes on the global database, which is the global influenza database. And it is believed that there are several 100,000 of viral genomes which are uploaded on this database. Now, we have to understand the nomenclature of the virus when we talk about the mutants. So there is the main nomenclature is the next strain nomenclature of clades, because they say that the initial virus was 19A, then there were the 19A and B. Then these viruses underwent an important mutation, which we'll talk about later, which gave rise to the 20A. Here 19 means the year where the virus was discovered. So this was the one in 2020. And this virus gave further, other clades of the virus like 20A, then 20B, 20C, and then others like F, D, E, F, G, etc. And these are the mutant viruses, which we'll, variant viruses, which we'll discuss later. And this is what the phylogenetic tree of the virus looks like. So if you look at this, these different colors represent different clades of the virus. So if you see from January 2020 to 21, there are some clades which are now not there at all. And there are some which are increasing because the structure of the virus or the clades keep changing. But apart from this, as if SARS-CoV-2 was not a complicated virus itself, you have another way of naming the virus, which is the pangolin way, in which basically what happens is each variant or each mutant virus is designated as A, B. Then this is a sublineage of B, which is called as B.1. Then this is B.1.1, B. 0.1.1.1, and when 4 ones accumulate, it is called as C. So both these methods are used for naming the COVID viruses, and that is why whenever you see the name of a variant virus, both these names will come, and that is why it is important to understand this. And if you look at the world map, you will see that most of the viruses which are circulating in the world, if you see, look at these purple viruses, it's coming from the lineage B1. Now, so before we come to the variants, we should understand a little bit about the SARS-CoV-2 genome. So this is basically a genome which is comprised of about 30,000 nucleotides. And if you look at it, there are various parts of the genome, and this part is the most important, the S1, because this is the genome which is coding for the spike protein, which is the main virulence factor of the virus. Apart from that, there are various other parts like the open reading frames, which are basically coding for the other non-structural proteins of the virus. Then there is the EG part, which codes for the envelope protein, M, which codes for the membrane protein, N for the nucleocapsid protein, etc. So remember that whenever there is a name given to any mutation, the first part will be the name of the protein which is affected. And you must understand the pathogenesis or the of the virus to understand why some mutations are more important than others. So all of us know that there is this spike protein, and this spike protein has two parts. It has one part which is the S1 part, which is the part which actually binds with the ACE2 receptor, and it has the S2 part, which is the other part of the protein. Now, when the virus attaches to the ACE2 receptor, these are the ACE2 receptors, then there are some proteases which are released from the cells, the human cells, which cleave the S1 and S2 subunit. And the S2 subunit actually causes entry of fusion of the virus with the host cell, and then the genome is released inside the cell. So while the S1 subunit is important for binding, the S2 subunit is important for the entry of the virus inside the cell. Hence, mutations affecting both these parts are important. And actually, the S protein does not have such a simplistic structure. It has a little complex structure. And the most important part of the spike protein is actually this blue part, which is called as the receptor binding domain. So while the spike protein is the big protein, the receptor binding domain is the one which is most important. And this receptor binding domain actually attaches to the ACE2 receptor, which is represented here. So that is why if you look at the spike protein also, the mutations which affect the receptor binding domain are more significant than the mutations which affect the other part of the spike protein. And that is why we keep talking about antibodies to the receptor binding domain, because they are the ones which mainly help in protection. So before we go to the mutants and variants, you must understand how the mutants are named. So the mutation is basically named like this. And what does this mean? S means it is a spike protein mutation. 614 means that it is the position of the mutation in the position in the protein. And the first letter represents the amino acid which was there in the original strain. And the last letter represents the amino acid which is now present in the mutant strain. So D614G means that there is a substitution where D, which stands for aspartic acid, is substituted by G, which stands for glycine. So this is how the mutations are named. And when you name variants, there are two types by which you can name the variants. One is a next strain name, which is actually the clade. Like I told you, there are different clades. So the British variant, this is 20I. This is the clade, followed by the mutation name. 501Y means that at position of 501, you have tyrosine now come in, and this is variant 1 because there are two other strains which have the same mutation. Whereas if we talk about the Pango lineage, then it is the variant is named by the lineage. So when we talk about the variants, they can be the variants of interest, which are under investigation, and they are variants of concern. So when there is a variant of interest, when does a variant of interest becomes a variant of concern? When either it is more transmissible and infectious, or it is more lethal, or it can escape immunity which can be provided either because of pre-existing infection, or it escapes the immunity provided by vaccines. Also, these variants of concern can reduce the efficacy of drugs and monoclonal antibodies. Like, you know, there are these monoclonal antibodies called Regeneron, etc., which have been made to target the viruses. So these monoclonal antibodies which were given to ex-President Trump can't work against some of these variants. And also, the variants can reduce the sensitivity of PCR tests. And that is something which is hotly discussed right now. But please remember that the mutations which reduce the sensitivity of the PCR tests have not yet been detected in the Indian variants. And if you look at the timeline of variants, then you basically have the D614G variant. This was the first variant which came into being because it was from the parent strain 19B, and the one which I told 20A was this D614G variant. And basically what happened here is that there was a substitution of glycine for aspartic acid. And this made the spike protein less bulky and made it easily attached to the ACE2 receptor. And now it is known that this is the variant which caused easy transmissibility of the virus, but it was not more lethal than the original virus. And also it did not escape the effect of the vaccines. In fact, the mRNA vaccines which are made right now, like the Pfizer and the Moderna, were made from the original strain of the Wuhan virus, whereas the other vaccine, like the inactivated vaccine Covaxin, was made using this strain. And of course, there was this mink variant which came in Denmark, and that was basically in the mink, there was a mutation in the virus, which then got transmitted to humans. Fortunately, this did not spread a lot, but 17 million minks were culled. So you must remember that these variants can not only arise in humans, but they can also arise in animals and then get transmitted to humans. So now let us look at the new variants which are circulating right now. So the first variant is the British variant. And this is the name given to this variant. And I've already told you why you have these two different names. This is by the Pango and this is by the next strain. And this variant emerged somewhere in September 2020, but it was really discovered, or it was really recognized in December, because what UK was seeing is that they had a rapid surge in the number of cases of COVID-19, much more than the previous weeks. And that made them realize that there is something else happening, which is exactly what is happening in Maharashtra right now, that the virus is highly, highly infectious. And this variant had basically 17 mutations. And the most important mutation which happened, while there were 8 mutations in the spike protein, the 2 mutations which were important were this N501Y, and this mutation made it more transmissible. And apart from this variant also had a deletion at 6970, which also reduced the sensitivity of PCR tests to pick up this virus. And what was found with this virus is that it is more transmissible than the original virus. And it was earlier believed that it causes increased number of deaths, but that is being debated right now. But what was good about this variant, that while it was more transmissible, it didn't really have an ability to cause reinfections. It did not reduce the efficacy of the monoclonal antibodies, and it did not impact the protection offered by the vaccines. So we all know that the Covishield vaccine or the AstraZeneca vaccine, which is widely used in the UK, where the main virus which is circulating is this UK variant, worked well. So that was good about this variant. Then we have the South Africa variant, again, which is given this name. And if you look, this is also having the same main mutation as the UK variant, but it is called as variant 2. Now, it came into being in August 2020, but it was recognized when, again, South Africa faced a huge surge of cases, and it had 9 mutations. One was the same as the UK variant, but it also had this E484K mutation, which was probably the immune escape mutation. So this variant was different from the UK variant because its ability to cause reinfections was more. So many people, 70% of the people who got infected in the second wave in South Africa were previously infected. It reduced the effect of monoclonal antibodies, and most importantly, it impaired the action of the various vaccines. So we all know now that the AstraZeneca or the Covishield vaccine does not work well against the South African variant. But the impact of this variant on Pfizer and Moderna is less, though the impact is reduced, but lab data shows that the amount of neutralizing antibodies which is generated by this Pfizer and Moderna vaccine can still affect this South African variant. And the other two vaccines, like the Janssen and Novavax, are moderately impacted by the South African strain. And if you look at the Brazil thing, again, Brazil had another variant virus. Again, it was somewhat similar to the South African variant. It had the same 2 mutations as the South African variant. And again, this was in its characteristics similar to the South African variant, because it also escaped the effect of, reduced the impact of Janssen and the Novavax vaccines. And the impact of this variant on the AstraZeneca vaccine is unknown. And then there is now in California, US, another variant described, though it is not described as a global variant so far. Again, there are 2 types of variants here. again having these mutations in the spike protein, it is more transmissible, and it also reduces the activity of the vaccine. So we must also remember one more thing, that when we talk about Pfizer and Moderna vaccines, that their efficacy is great. Remember that these vaccines were tested when none of these variants were widely spread. Whereas the Janssen and the Novavax vaccines were tested when these variants were more common. So therefore, we must not think that if the efficacy of these vaccines, the Janssen and Novavax, is 70 to 80%, it is poor as compared to the Pfizer and Moderna vaccines, because even if the Pfizer and Moderna vaccines were tested at this time, maybe their efficacy would also be low. And right now, if you look at the distribution of the clades and the various variants, you look at this, which is the most widespread variant in the world, which is the UK variant. This one. And if you look at this UK variant, it is very common in Europe, and it is also common in India. Whereas if you look at the Brazilian variant, which is V3, it is mainly seen in Brazil. And if you look at the South African variant, which is V2, it is mainly seen in South Africa and African countries. So with that background of the variants, we must understand what is the situation in India. Now, we must remember that the ability to detect variants depends on how much whole genome sequencing is happening. So if the country is sequencing a lot of its isolates, you will detect more variants. And that is true for UK, because it is now believed that of all the viruses which have been isolated in the UK, 10% of them have been sequenced. And these other countries have also sequenced their viruses. Whereas as far as India is concerned, it has sequenced a very, very small percentage of its viruses. And therefore, we may not be detecting how many variants are actually circulating. Because of this, the INSACOG was launched in December 2020, binding 10 labs together to sequence the various kinds of, isolates which are present in India. And if you look at this website, this is a live website where you can see what are the kind of, based on about 10,000 isolates that they have sequenced, what is the current distribution of the clades and the variants. Now, if you look at this, this is the UK variant V1, and if you can see, it is becoming increasingly common. Whereas if you look at the South African variant, there are few cases, and if you look at the Brazilian variant, there are very few cases. But remember that this is these 10,000 isolates have been tested over the past 9 to 12 months. So we don't have real good data about what is happening at this time, because this is just a live website, and I just want to show you how it works. So this is a live website which you can go to, and just 1 minute, I hope it shows up. It's not opening. Okay, maybe. So I think it's taking time. So if I have time, I'll show it to you later. So if we look at the situation of mutants and variants in India, as I said, we have only sequenced 0.1% of the total cases. And we have detected out of these 10,000 samples, 771 variants. And if you look at them, most of the most common variant is the UK variant, which has been mainly detected in Punjab. And there are few cases of the South African and the Brazil variant. But more important than that, we have other mutations which have been detected. So we have India-specific variants now. And what is most relevant to us is this double mutant in Maharashtra. So this double mutant in Maharashtra has this L452R and E484Q. Now, this L452R is the same mutation which was found in the California variant, and E484Q is the mutation which was present in the Brazilian and South African variant. So this is already been designated as a separate lineage, but the government has not recognized it as a variant in India so far. But I think for all practical purposes, we can assume this to be a variant. And today, somebody told me that of the 442 isolates which have been sequenced by National Institute of Virology, Pune, 60% are the double mutants. And I think this can explain why we are having a sudden surge of cases in Maharashtra. And you know that we are all going through an unprecedented thing. So what has been the government think till now is that this rising number of cases are because of carelessness of people. People are not wearing masks at all. But I think slowly they are realizing that it is not just this. It is because of a mutant virus and a variant virus. So please remember that why does it seem that this surge is because of a variant virus? Because the precautions had been down since November of last year, but there were really no cases. And we are seeing a different kind of virus right now. We are seeing all family members are infected. So if you have one person infected, all 6 people are infected, whereas in the first wave, you would find that surprisingly only 30 to 40% of the family members would be infected. The other thing which you are seeing is that healthcare workers who were working through the previous year in close contact with patients are getting sick. Because, we are thinking that maybe the people who didn't go out at all last year and now are going out are susceptible, they have no immunity. But we have healthcare workers also who are getting infected. Children are getting infected with more symptoms, and that is the main point of discussion today, because it is believed that children are 50% less susceptible to getting infected than adults. But with the current virus, they are becoming more infected and more symptomatic. Young patients are becoming sick. And we are seeing people who are getting infected despite 2 doses of the vaccines, suggesting immune escape, though most of the cases are mild. Now, we know that 20 to 30% of people will get infected even despite 2 doses, but we are seeing clearly more infections and we have reinfections that are increasing. So that is why we have a mutant virus or a variant virus in plain Maharashtra. And I think this is the same virus which is spreading all across the country, because Maharashtra always leads the wave. So the first wave was also happened in Maharashtra, and now we are seeing the same cases happening all over. So this is what is the situation, and what we need to do at this time is do whole genome sequencing of representative samples, and especially after people who get infected despite complete vaccination and in reinfections. We need to ensure strict masking, social distancing, and a lockdown, because I think at this point in time, a lockdown is needed. Otherwise, the healthcare facilities are getting completely overwhelmed. And we need to ramp up vaccination, because even though there are variants circulating, it is possible that the vaccines will at least reduce the severity of disease if they don't reduce the infection. So I think with this, I like to conclude the first part of my talk. And should we take questions for this talk now, or should we take it in the end?
Madam, I think we'll take it at the end.
Okay. So I just wanted to show you this website, that it is a live website. So, for example, this is, if you click on this virus, this bubble which represents one virus, you can know where it was, who has put it up, what are the various mutations, etc. So this and when was it reported? So this is kind of a live website which you can go to. I think with that, I want to come to the second part of my talk, which I think is more practical for more people. For most of the people. So I'm going to be talking about diagnosis and management of COVID-19 in children. So first, Dr. Yevle was going to give this talk, and he would be talking on the clinical features. So in very briefly, what I want to say is that the main clinical features that we are finding of COVID in children at this time is fever. Most of them have fever. Some of them have runny nose. Some of them have cough. Many of them have diarrhea. And what is unusual at this point in time is that whereas in the earlier wave, the fever would go away in 1 or 2 days' time, now we are finding that the fever is going on for a long time. So the first question which we have, which is in the minds of the doctors, is that when and how to test for COVID-19 in children. So if you look at the broad guideline by the government, then all children who come with a severe acute respiratory illness, that means who have fever and cough and who need hospitalization, should be tested. All patients with an influenza-like illness, that means those who have fever with any respiratory symptom, should be tested. All asymptomatic contacts of positive patients should be tested. All newborns born to COVID-19 mothers, all suspected MIS before procedure or before any hospitalization. So these are the broad guidelines. But there are so many practical issues. So what I'm going to do is, after the initial part of my presentation, I'm going to talk about certain case scenarios so that we can discuss this dilemma about testing a little more. And The other important thing is what to use for testing. So you should RT-PCR in the nasopharyngeal swab is the test of choice because it has better sensitivity than the antigen test and RT-PCR on oropharyngeal swab, and it can be sent on day one. So we must understand that you don't need to wait for 2 to 3 days to send the sample because most people are actually positive in the nasopharyngeal swab even before the onset of symptoms.
Madam, your presentation is not visible. Have you shared it?
Oh, okay, 1 minute. Sorry. I didn't share it. Okay. Now, can you see it?
Yes.
Yes. Yeah. So if you look at the diagnostic algorithm, you have a patient, a child who has suspected COVID. You can ask for an antigen test in nasopharyngeal swab, and if you do the antigen test, and if the antigen test is positive, it confirms COVID. There is no doubt about the diagnosis because the test is highly specific, though it is poorly sensitive. If the test is negative, then you do an RT-PCR. And if the RT-PCR is positive, again, COVID is confirmed. But if the RT-PCR is negative, then you have to retest probable COVID because at this point in time, COVID is the most common cause of any acute illness in patients. So even if the PCR comes negative, you have to think of it as COVID and continue to isolate the child. You can look at other reports. You have to rule out other illnesses. You can repeat RT-PCR again. Maybe the first sample was not collected properly. And we must also understand that at this point in time, the labs are also highly burdened. So therefore, it's possible that the samples, the accuracy of the sample testing is being compromised. And last but not the least, you can do an antibody test after 2 weeks. Now, the next question is, what is the role of CT chest in children with COVID-19? So we must first understand when is it not indicated. It is not indicated in children with mild disease because what is happening is all adults, who have COVID, their doctors are advising them to do a CT scan. So now if they are infected and they have been done a CT scan, if their children get COVID, they they get a CT scan done for the child even without consulting you. So you have to keep emphasizing that it is not indicated in mild disease. It is not indicated even if the fever is going on for 3 4 days unless you're suspecting a lower respiratory tract involvement. And also, you don't need to do it for clinically diagnosed severe disease with positive RT-PCR because if a child comes to you who's a positive RT-PCR and is breathless and is hypoxic, you know it is COVID pneumonia. So it's not absolutely essential to do a CT. When is it indicated? It is indicated one in clinically suspect patient of COVID-19 who has prolonged symptoms but who has a negative RT-PCR. So here, if you see the typical ground glass opacities in the lung, then you can diagnose it as COVID. The second situation where you need to do it is in acutely sick child with breathlessness, where you need to determine cause of illness and triage is needed. So a child comes to the emergency with fever and breathing difficulty. You know the RT-PCR results will take some time unless your unless your hospital has an in-house lab. So you can quickly do a CT and decide whether the child is having COVID or not. And also you should do it in a known case of COVID-19 who has deteriorated because it will help you to determine the cause of deterioration, whether it is progression of the COVID itself or whether it is some secondary bacterial infection, etc. So these are the roles of CT chest in children. Now, how do you manage asymptomatic asymptomatic COVID-19? Because that's the first question, that you have parents who are positive and they have tested their child and the child is positive, but the child is not symptomatic. Now, it is very difficult to determine whether a child who is asymptomatic is either pre-symptomatic, that means he's going to go on to get symptoms later, whether the child is truly an asymptomatic carrier or the child had COVID one or a few weeks ago and now is just carrying the RT-PCR in his throat. So this dilemma is difficult, but how can you solve this dilemma? By finding out whether the child was ill, what is the contact history. So for example, if you know you have many people in the family who are currently positive and this child is also positive, then you know that this child is having an acute infection, and though he may be asymptomatic right now, he can go on to develop symptoms in the next 5 to 6 days. And also the CT value may give you some idea in an asymptomatic child, because if you have a high CT value, it means that the infection was old. But remember that the CT value also depends on how the swab was collected. So if the swab was not collected properly, you can get a high CT value even in early infection. But if you have asymptomatic COVID, you don't need to do any intervention. You isolate the child with the parents. You watch for development of symptoms for the next 10 days. You have to counsel them that while the child is asymptomatic now, symptoms can happen over the next 10 days. And if the the child was tested prior to any surgery or procedure, it may have to be delayed for at least 10 to 14 days because you don't want to perform a elective surgery or procedure in a child who's incubating COVID because the outcomes of these children may be worse. Then how do you manage children with mild COVID-19? Mild COVID-19 basically means that the child does not have any clinical features of lower respiratory tract involvement or other organ dysfunction, because we must understand that sometimes COVID-19 can present as encephalitis, sometimes it can present with acute abdomen and other features. In these patients, you just give them symptomatic care with paracetamol or ibuprofen, nasal decongestants, and antitussives. There is no established role of zinc, vitamin C, vitamin D, steam, etc. But remember that, even if you don't prescribe these medicines to the patient, they will themselves take, and they think that you're doing some gross injustice by not giving. So I don't argue with the parents on this. If they want to have vitamins C and zinc, let them have it because it's not harmful. But I would be cautious about giving therapeutic doses of vitamin D without a level. There is really no role of antivirals, including azithromycin. There are enough double-blind trials which have shown that azithromycin does not work. There is no role of doxycycline. There is no role of ivermectin. In fact, the WHO has warned against use of ivermectin, and there is no role of favipiravir also. Because while the interim analysis of favipiravir showed that it did reduce symptoms and clearance, the final result showed no impact, and it's an expensive drug, and basically it is not approved for children below the age of 18 years. Why this discussion on antivirals is important? Because all the adult people in the house will be on one of these antivirals because their physicians would have prescribed it. So they will always ask you the question about giving these antivirals to the children. There is no role of any investigations, including CBC, CRP, D-dimer, or CT chest. No role in the first few days. You just have to tell them about monitoring the temperature and saturation, and you would ask the parents to tell you that if the fever is not going away in 4 or 5 days, or if the child is becoming breathless, or if the saturation of the child is going below 95%, then they need to come and consult with you. Many of them have read about MIS, so you will have to tell them that there is a very, very small risk of MIS, and it is very, very low, because otherwise, even if the child recovers from the COVID illness, they'll keep worrying about MIS later. However, these principles don't apply to immunocompromised children with mild COVID-19. So if you have a child on cancer chemotherapy or high-dose steroids, but underlying chronic lung disease or congenital heart disease with COVID-19, you have to be careful about these children. Ideally, these children should be observed in hospital, and you can consider early use of antivirals in these patients. And the two antivirals which are available to us, which may have some efficacy, is Remdesivir, which is again a problem because there is shortage of Remdesivir, or convalescent plasma, because actually convalescent plasma is useful if it is given in the first few days of the infection when the person does not mount his or her own antibody response. Now, what about children with prolonged fever? And this is the most difficult thing, because for mild COVID-19, it is easy to manage them. For severe COVID-19, as I will discuss later, it is easy to manage because these people go into the ICU and they are treated by the intensivist. The commonest problem which people will face in their practice will be children with high fever going on for 4 to 5 days. And this is not uncommon these days. Over the past 1 or 2 weeks, I've come across several children with this problem. Now, here you need to do investigations because for two reasons. One is that the investigations will tell you what is the severity of COVID or the likelihood of progression, and it will also help you rule out other causes. So in these patients, one should do a CBC with absolute lymphocyte count, because if you find that the absolute lymphocyte count is less than 1000, it means that the risk of progression is higher. You should do a CRP because it will also tell you about how severe the disease is. D-dimers can be done. There is no data of supporting use of D-dimer in children. You should do an SGOT, SGPT, creatinine, because These will also tell you about any organ dysfunction which is happening, and COVID-19 antibodies. Why am I asking for COVID-19 antibodies? Because many children who will be RT-PCR positive and having prolonged fever may actually be having MISC, because they may have had an episode of COVID 3 to 4 weeks back from which their PCR is still positive. And that is why you could do a COVID-19 antibodies here. And you should do a malarial parasite, ultrasound, abdomen and pelvis and chest x-ray, just to make sure that you're not missing out on any other cause, like urine routine. I didn't put it here, but you should do a urine routine, because it is possible that your child may be having a bacterial infection, which you think is due to COVID. And CT chest is also not needed here. Close monitoring of these children is needed. You should give them antipyretics. And what is the role of steroids? Again, I'm going to discuss a case or two where the same was used and what happened. But basically, we should not use steroids before day 7 unless the children are hypoxic, because it increases the viral replication. And again, if you are sure that your patient has only COVID and no other co-infection, there is no role of giving antibiotics here. And how are you going to manage this subset of children? We will discuss in a couple of cases. And then what to do about severe COVID? I'm not going to spend much time over here because many of them are looked after by intensivists, but basically defined as COVID with hypoxia. You have to admit these patients to the isolation unit, do all the tests which are routinely done in adults, and you do PCT, IL-6, ferritin, LDH if available. Treatment as per adult protocol, so basically oxygen by nasal cannula, face mask, NRBM, HFNC, etc. Awake proning, prophylactic dose of low molecular weight heparin, no role of antibiotics unless they are co-infections. And steroids are definitely indicated here. So sometimes if you get a call from a parent saying that their child has COVID and is running fever and now the saturations are dipping below 94, while you are trying to arrange for a hospital bed for such a child, you can start steroids, oral steroids pending that admission. But remember, this has to be for children who are hypoxic. And there you can use either 1 to 2 mg per kg of methylprednisolone or an equivalent dose of dexamethasone and give it for 5 to 10 days. And if this patient is admitted to the hospital, you stop at discharge unless the patient has ongoing oxygen requirement. Remdesivir is another drug which is indicated in severe COVID-19. There is a lot of controversy about the drug in adults, but basically this is the only antiviral which may work. And though there is no lower age cutoff for giving remdesivir, it may be given to children with a weight of more than 3.5 kg. So effectively, it can be given from the newborn period onwards. Loading of 5 mg per kg and maintenance of 2.5 mg per kg for 4 days in children below 40 kg. And those above 40, you give the adult dose. And the drug is relatively contraindicated if the patient has renal dysfunction or if the liver enzymes are more than 5 times normal. So before you actually give remdesivir, you have to check the creat and the liver functions. And that's why I said in a patient with prolonged fever, you should do these tests. In children with severe disease who are not improving with steroids, you may use tocilizumab, because tocilizumab use has been revived again after the recovery trial and remap-cap trial, which showed that tocilizumab is beneficial in a certain subset of patients with severe COVID-19 with high inflammatory markers. Convalescent plasma is not of any use in this phase, because by this time the children already have developed their own antibodies against COVID-19, and there are other drugs which have been used in adults like baricitinib, which is not approved in children, and abroad people are using Anakinra in children, which is again not available to us. So from management, let us move to isolation. So this is also an important question. So remember that infected children are to be isolated with parents, even if the parents are asymptomatic, unless parent is high risk. So many times you have a child who's positive and the parents are asymptomatic, or maybe they are positive but asymptomatic, or one parent is positive, the other is not. So you can keep the child with the parents unless one of the parent is high risk and is not infected, then that parent can be separated. Another important thing is that when these people are isolated together, they don't need to wear masks, because it is not that one person can reinfect the other person. Because sometimes what happens is in a family, there are 4 people, all of them are positive, and they say, no, our CT value is 13, uska CT value is 25, so we don't want to use. So it's not that you can infect someone else or you can give more virus to someone else. So please counsel that if they are together, they don't need to wear masks. The second situation is if the parents are positive, the children should be isolated with the parents, even if the children are asymptomatic. They should not be sent to grandparents or anybody else's house, because these children, even if they are negative, it doesn't mean that they will not get infection later and they will transmit the infection, because this is very commonly done. The moment the parents realize that they are positive and the children are well, they send the children off somewhere. Some of them don't even do a PCR test. Children have to stay with their parents, and you have to counsel the parents that children are at low risk for severe COVID. The only exception to this rule may be if there is a child who is having high number of comorbidities, like you have a highly obese adolescent or you have a child who's immunodeficient, then that child should, if the child is asymptomatic and test negative, should be isolated away from the parents. But otherwise, if the child is otherwise healthy, the child can be kept with the parents. And many times it happens that one person tests positive in the family and the other people are asymptomatic. They test all of them together. Ideally speaking, that person should get isolated and the other contact should be tested after 5 days, because in these 5 days they may either get symptoms of COVID, or you will be better able to exclude COVID infection if you test them after 5 days. Now, if the person is constantly in touch with the other person who is infected, then there's no point in doing a PCR after 5 days, because the patient is still at risk for acquiring COVID from the contact. And in that case, you may have to do the PCR 15 days after the day symptoms started in the parents, because for the first 10 days of symptoms, the parents are infectious. So 10th day will be the last day that they're infectious, and another 5 days from them, then you can test the child. Now, with this kind of brief background about which children to test, how to investigate, how to manage, and how to isolate, let us quickly discuss some case scenarios. So, and discuss how we will apply these principles to these cases. So, this will tell you that actually the diagnosis and management of COVID is highly individualized. And while you have broad guidelines, you have to manage each child in a different way. So, for example, this is a 3-month-old baby boy, previously healthy and on exclusive breastfeeding. The father, the child has fever up to 101 for 1 day with runny nose. The father tested positive for COVID 1 week ago, and the mother is asymptomatic. She's a doctor and she's already received the COVID vaccine. And the child also has grandparents at home. So the first question is, will you test the baby? See, if you look at the guidelines, then this child will need testing because he's in contact with a positive case. But in practical situation, this may not be needed because for all practical purposes, this child is COVID. So you can assume that this child is COVID and treat the child accordingly. What treatment are you giving to this baby? So this baby has mild disease. The fact that he's an infant does not really increase the risk too much. So you will just give paracetamol and nasal saline drops. You're not going to give anything else. How will you isolate the baby? The mother is asymptomatic, but you will still keep the baby with the mother and not give the baby to anybody else. And the mother and baby pair should be isolated from the grandparents at home. Now let us come to a second case, which is reverse of the first case. Here is a mother who is COVID positive and has mild symptoms. And she has a 7-month-old baby who is asymptomatic. And the baby is on breastfeeds and weaning food. And what the mother does is that she breastfeeds the baby and then gives the baby to the mother-in-law. Now, what the first thing is, who should the baby be with? So obviously, when this happens, the biggest worry of the parents is the baby, because the baby is asymptomatic. So they feel that the baby should not be kept with the mother as far as possible. But please remember, the baby has already been in intimate contact with the mother. And if this virus is as infectious as we are seeing right now, the baby in all practical reasons is already infected. So this baby should not be given to the mother-in-law who is actually at risk for comorbidities. And the next question is, should the baby be tested and when? So again, if you look at the guidelines, they say that all asymptomatic contacts of COVID positive patients should be treated. But here it is, there's really no point in testing, because also you must understand that the labs are completely overburdened with tests. So even if you send a test, you may not get it back. So in these situations, it is better to avoid testing and to reduce the burden of the various PCR labs, because somebody sent me a message today that in Pune, my sister-in-law's brother and all are infected in Pune, and they wanted to get a PCR test done, and the time is 3 weeks, 3 days. So what's the point of testing this kind of baby here? Now let us come to a third case. Now these cases, now the first two cases, the decision was easy. Now let us come to this third case. Now this case is of a 13-year-old child who weighs 53 kg. So obviously the child is overweight. He gets sudden onset high fever for one day, reaching up to 102 Fahrenheit. And he has a runny nose also for a few days, but there's a known history of allergic rhinitis. And when the parents actually called me, they thought that the child is having bacterial sinusitis because 1 year back, the child had the same symptoms of cold and then went on to develop fever. But when you ask a history, you find that the father and grandfather had mild sore throat the previous week. And when I asked that whether anybody in the family has COVID, they said nobody has COVID. So that is also an answer which you may get. But then you have to ask more clearly. You have to ask, is anybody in the family sick now? Or did somebody have was sick last week? And then they'll say, हाँ, पहले एक हफ्ता पहले किसी को सर्दी खांसी था, पर वो तो एक दिन में ठीक हो गया. वो कोविड नहीं था, वो तो नॉर्मल वायरल था. Because many of these people, if they go to the GPs ना, they will say कि इसको तो नॉर्मल वायरल है, ये कोविड नहीं है. Because most people believe that COVID is actually a very bad illness which comes with high fever and which lands people into the hospital. But if somebody comes to you with this kind of history in today's age, you know that you are possibly dealing with COVID rather than bacterial sinusitis, and the family members probably had COVID last week. So the first question is, will you test the child or give symptomatic therapy? Now again, it's a little difficult question to answer, because a lot of it will depend on how willing the parents are for testing. So you may give just symptomatic therapy to the child and ask the child to be isolated with in the house and away from the grandparents. And will you, suppose you decide to do tests, will you do just COVID-19 PCR or you will do other tests? Now, in the situation today, when all fever is just because of COVID and other infections are not very common, it makes sense to first just do the COVID-19 PCR. And if the COVID, because even if you do these tests today, it may not tell you about the severity of COVID because this is just the first day. So you can just do the COVID-19 PCR. However, if this child would come to you after 3 or 4 days of fever, then it makes sense to do both the PCR and the other blood tests at the same time, so that one, you will be able to make the diagnosis in parallel, and you will also come to know what is the likelihood of severe COVID in this patient. And the third question is a hypothetical question, that suppose you saw a child who has fever, but nobody in his family is sick, nobody is going out, and then would you test the child for COVID? The answer is yes, you should still test the child for COVID, because we are seeing this quite often, that only the child is infected and other people are not symptomatic. It may be that they are asymptomatic carriers. It may also be that they had been infected earlier and are actually immune. And therefore, even if no contact is sick, you should still test the child. Now, in this same case, the fever persists and the child tests COVID-19 positive. The CT value is 18, and day 3, the child is still running fever. So the first question is, does the CT value help in any way? And many times, if you are doing a consultation for these children, you find that first thing they will say कि हमारा CT value 18 है. And you have to be careful, because sometimes whether they are speaking about the CT value of the PCR or whether they're talking about the CTSS scoring of the CT, you don't know. But because everybody in the common public also thinks that if the CT value is low, it means that the viral load is high and the patient will get severe COVID. So the answer is no. The CT value does not predict the severity of the disease. It just tells you the recentness of infection. So if you test a person 1 or 2 days after the symptoms started, your CT value will be low. And if you test somebody after 5 to 7 days, your CT value will be high. So the first thing you do is you reassure them that no worries. And sometimes if 4 people in the family have tested positive, they will relate the CT values of all the family members, and they will want to know why the CT value of somebody else is different from somebody else. So you have to just reassure them. Now, the other question is that this child on day 3 is still running fever. So would you like to do some tests or would you like to wait? So the answer is that, at this point in time, that this is COVID only. And it is still the third day. So you may or may not want to do other tests for this patient. You could even, because many patients actually get better by day 3 and day 4. So you could, especially if the child is not worse than what he was on the first day, or if the fever spikes are coming down, or the interval between the fever spikes is increasing, you may choose to withhold these tests. But in some patients, if you find that the child is actually worsening, if the child's requirement for antipyretics is going up, then you may at least do a CBC, CRP, D-dimer, but CT chest is not indicated at this point in time. We can't do CT chests in children like we do in adults. Remember, a CT equates to about 100 X-rays. So please don't do a scan here. And the other question is that favipiravir be given, because we said that favipiravir has no role in small children, but this is a child whose weight is like an adult, and adults in the family are all eating favipiravir. So again, we would not prescribe. It's not approved, and second, it doesn't help. If it was not approved but it is known to help, we could have still given it off label. The next question is that should the patient be hospitalized for remdesivir? So the answer is no, because see, right now it's just day 3 of illness. And also the fact that most of these children by statistics will get better on their own. And remdesivir is a drug which is in serious short supply, and it is basically needed more by people who have severe symptoms, adults who have severe symptoms, or who are requiring low flow oxygen. They are the people who should be prioritized for giving remdesivir. And then the next question is, suppose you reassure the parents and you say hospitalization is not needed, when would you consider hospitalization? Again, that depends on a lot of factors. You may want to hospitalize the child, but beds are not available. So, but I would say that anything beyond day 5, day 6, if the child is not improving, we should actually look at that child more closely, because problems may set in. And in this same child, the fever went away on day 4, CBC was normal, D-dimer was 800, CRP was mildly elevated, and they went ahead and did a CT against your recommendation, and the CT score is 5/25, and they're all panicking. So does anything else need to be done here? So the answer is no, because the child's fever has gone away. D-dimer of 800 is elevated, but this child does not merit any anticoagulation, doesn't merit any clexane or aspirin. And also the mild involvement which is seen in the CT does not need any intervention, because even if you do CT scans of people who are having very mild symptoms or even asymptomatic for COVID, you can find GGOs in the lungs. And basically that is one way how you diagnose COVID if the RT-PCR is negative. Then let us come to the fourth case. The fourth case is a 5-year-old child, has fever for 1 day with sore throat. Parents are doctors and have received both doses of the vaccine, and they are asymptomatic. So the question is that will you maybe not test this child, but will you consider COVID-19 in this child? Because the child is at home, the child is not going out, and parents have received the vaccine. The answer is yes, because we must understand that even after the vaccination also you can get infected and you may be asymptomatic carriers. So if you should consider COVID-19, and you maybe in 2 or 3 days, if this child is not better, you should test. Now let us come to a case which I saw just yesterday, and this child is getting admitted today. This is an 11-year-old girl weighing 63 kg. So obviously this is overweight child. Family COVID-19 positive. The father is currently admitted to the hospital. The child has fever since April 5th. So that is 10 days now, and test COVID positive on April 6th. And now has been running fever 100 to 101 daily for 9 days. And they went ahead and did a CT chest, and the CT showed a severity score of 10/25. Now remember that this patient is a little different from the previous patient, because your fever is going on for 9 to 10 days. And this child is advised steroids. And the child is basically not tachypneic. The child is not hypoxic. The saturations are 97, 98. So what will you do in this patient? Will you consider this patient for remdesivir? And what will you do about steroids? So, so coming to this same patient, this is a difficult situation. But, in this, we cannot dismiss such a child, because this child may go on to complications. So ideally speaking, in ideal circumstances, if beds are available, this child should be admitted. The child should have a CBC done to look at the absolute lymphocyte count. The child should have a CRP and D dimer done. And if remdesivir is available, it should be offered first, because this may still be we are still within day 10, so it may still work, because we know it doesn't work after day 10 and 14. And if the child has any deterioration or hypoxia, then we can give steroids. Now, this same child, I'll give you a follow-up because I prepared this presentation yesterday. The same child was given 20 mg of steroids yesterday, and she took that first dose before she consulted me. So I asked her to hold on to steroids. Now, since today morning, the child has no fever, but the saturations have dropped to below 95. So we are admitting here. So therefore, it tells you that such children who are having fever going on for 9 to 10 days may actually worsen, and hypoxia may happen quickly. And you have to be careful about these patients. So what we are going to do after we admit this patient is we are going to start her on remdesivir. We are going to continue steroids for her because now she's a hypoxic. And then the last case tells you how a case of COVID-19 should not be managed. This is basically to tell you how it should not be managed. So this is a 14-year-old girl. The parents tested positive for COVID-19 on 15th March, and they were admitted. And they did a test for the same child who was tested negative on 23rd March. And the child, however, developed fever on 26th. So this is what happened. So initially, the child may be still incubating the infection, developed fever on 26th. She was treated with oseltamivir and paracetamol. Now look, why was oseltamivir given? Because there's no flu here, and oseltamivir has no activity against COVID-19 virus. And so there was no role of giving oseltamivir. However, the test which was done on 27, the COVID PCR came positive, CT value of 29. Now that's odd because this child has early infection. So why is the CT value high? So this is just to tell you that sometimes your CT value can be misleading also, because on 23rd this same child tested negative. Now basically this child has hemoglobin of 12.4, TLC of 7,800, CR absolute lymphocyte count of 5,000, platelets are normal, CRP is normal, ESR is 9. So this is basically a very mild COVID infection right now, and the fever resolved, and the child did not have any symptoms. So probably you have a child who's got better with mild COVID. Now it's not over. On day 30th of March, when she did not have any symptoms, a CT scan was done. And if you look at the CT scan, you find that she has GGOs, and basically GGOs were there mainly on the left lower lobe, and it was reported that the CT severity scoring system was 6/25. And this patient was started on favipiravir and steroids. So was there a need to give her favipiravir? No, because she was not having symptoms. And was there a need for giving steroids? Absolutely not, because she was not hypoxic. Next day, she goes and sees a pediatrician. So the pediatrician puts the patient on antibiotics, which is ceftriaxone, amikacin, coamoxiclav, steroids on OPD basis. Because on 31st, she starts running fever again. Now, if you look at this case, on 31st, if she starts running fever again, then it is probably the COVID itself which is causing the fever. It is unlikely to be a bacterial infection because we are not seeing bacterial infections within the first 7 days of COVID-19 illness. So these antibiotics are not needed. And steroids also we shouldn't be giving to this child because the child does not meet the criteria for steroids because she's not hypoxic. And again, she doesn't have any fever on 2nd. So 31st, these treatments were started. On 2nd, she has no fever. And she remains afebrile for 3 days while on antibiotics and steroids. So, but on the 5th, she has again high fever. And if you look at this, this time you find that her absolute lymphocyte count has declined. The CRP is still normal. And COVID antibodies are negative because people were wondering whether she has MIS now. Maybe she had old COVID infection. MP was negative. Saturations were still normal, but she had reduced air entry in the right lung. And when a CT scan was done, you found that while the left lower lobe GGOs had cleared, she had developed new GGOs in the left upper lobe and on the right side. And now the CT severity system scoring was moderate. So this is a patient who is having now fever on approximately, this is now day 10 of illness. while on antibiotics and steroids. So what do you do for such a patient? What is this recurrence of fever due to? Is it because of an acute COVID illness? Is it because of a secondary bacterial infection, which seems unlikely because the patient was already on antibiotics and the CRP was normal? Is it MISC, which is again unlikely because in MISC you don't have so much of lung involvement? And what should be done in this patient?
Yes,
Would we just treat the patient fever symptomatically? Should we offer remdesivir? Antibiotics and steroids have no role because the patient has got these symptoms while on antibiotics and steroids. And could giving steroids in the early phase have enhanced viral replication? That is a possibility because the patient was given steroids when they were not indicated. And even the recovery trial showed that when patients were given steroids earlier than day 7 of illness, they had bad outcomes. So we actually admitted the child, her CRP had gone up, her D dimer had gone up. We started IV remdesivir and low molecular weight heparin, with which there was prompt resolution of fever. We discharged after 5 days of remdesivir. When her CRP came down and the D dimer reduced, we did not offer any anticoagulation at discharge, and there's no need for CT scan at follow-up. So this case tells you that you will now see patients who are having COVID pneumonia, this case and the previous case, especially in adolescent children, where you may have to use antivirals. And this case also tells you that remdesivir works because we have had numerous cases who were given steroids and continue to run fever. When you give remdesivir, the fever comes down, and you can't explain that this fever came down just by chance because the patient, when the patient was admitted, was having 102 fever and had such a high CRP. And within 1 or 2 days of one dose of starting treatment, the fever went away. Like how after starting antibiotics in a serious bacterial infection, your fever goes down and your CRP comes down. So I think with that, I just want to kind of end my presentation because I think I'm already 5 minutes beyond time. That though we are seeing severe symptoms in children at this present time, children still fare better than adults. So we have to understand that 95% of the children will get better with just symptomatic therapy. The decision to test a child with symptoms will have to be individualized. And please remember, when you have a straight off case of mild COVID-19 with parents being positive, you should not really test the child because anyway, the tests are in shortage. And also remember that symptomatic care is all that is needed for the vast majority, even with mild COVID, unless the child is immunocompromised. The children have to be isolated with the parents unless the parent is at high risk for developing COVID-19 severe disease. And remember that most parents are usually positive. Also, understand that if a child who is suspect or confirmed COVID-19 continues to have fever for more than 4 to 5 days, you have to also look for other causes of fever, and you also have to look at, presence of, make sure MIS is not there. Steroids have to be used with caution. Please don't use steroids in children earlier than 7 to 10 days of the illness just to bring the fever down because it will increase viral replication. Use steroids in children who are hypoxic. And if you are following up a child in the OPD who has saturations now dipping below 95%, who is not getting a hospital bed, you can start steroids in such children. And finally, I think as Dr. Bhakti will discuss later, that there are many mimics to MISC, and you have to make that diagnosis after excluding other causes. And then one last line about as the tests are in short supply, as hospital beds are in short supply, so also remdesivir is in short supply. So you have to be very, very careful about which patient to offer remdesivir and whom not to offer. I think with that, I want to end my presentation and, just take a little break. Thank you.
Thank you. Thank you very much, ma'am, for such a nice presentation. You have covered so many things which are currently very much needed. Mutants, variants, everything. Most of the doubts are covered in your presentation, which are very helpful in our day-to-day practice. Thank you very much for such a nice presentation. Now we will move to next topic, which is very important, not to miss, MICS, which is going to present by Dr. Bhakti Sarang. He is an associate professor and head of pediatric critical care services at Bharati Vidyapit Medical College and Hospital, Pune. He is a certified quality improvement coach by NQOCN in 2018. He is a IAP certified instructor for BLS and ALS. He is a PICU fellowship coordinator and in charge PG teacher in Bharati Vidyapit. He has so many publications included in journals. He is the author the book Encyclopedia, the bedside guide to general pediatrics. Over to Bhakti sir.
Good evening, everyone. Thank you for having me here. Thank you for the introduction, and thank you, Tanu ma'am, for that very elaborate session. And really, a lot of things on my mind also have been cleared with that. It's always a pleasure listening to you. Now, without further ado, I'll just quickly move on to my talk, which is basically talking about MISC. I'll just share my screen now. Is the screen visible to all?
Yes, yes, sir.
Yes, yes.
So in the following 20 minutes, what we will essentially do is try to not cover what has already been done, because ma'am has spoken very elaborately about everything else. We'll just look at the definition of MISC, look at when we should start suspecting MISC, how we should go about evaluating, who to treat and what to give, and look at outcomes as on today, what we're looking at, and what we're expecting in the long-term follow-up of these patients. Now, at this time last year, if you remember, just about a year ago in April, we were all, struck with the pandemic, and we all believed, and some evidence proved that children largely were spared from a severe SARS-CoV-2 infection. The severe disease was risk of severe disease in children was very low, and prognosis of mild or moderate disease was also fairly good, with recovery between 1 to 2 weeks. And death happened to be an exceptional event. But little did we know that things were about to change. In May, obviously things changed when the RCPCH reported the hyperinflammatory syndrome for the first time. A clinical picture that was previously unknown emerged. And in the coming months, we were hit with many terms by RCPCH and CDC and WHO, things like PIMS-TS and MISC and MAS and TSS and KD and hyperinflammation and cytokine storm, etc., all of which with much of overlap and a lot of confusion related to the what is PIMS versus what is MISC, etc. So a lot of time was spent in dealing with this confusion. However, this syndrome changed the notion of COVID being a milder illness in children, or the repercussions of a COVID-19 infection being mild in children to an extent. I wouldn't say entirely, but it partially changed the game for all of us as pediatricians. And as already discussed by ma'am, the second wave is bringing in, sicker kids with active infections, which is again, thanks to the mutant strains and all the other factors mentioned by ma'am. Now, when we look at the definitions, it's a bit of a paradox, actually. I've mentioned two definitions here by the WHO and the CDC. I haven't mentioned the RCPCH one. The thing about the definitions is that they all have common elements, such as, the age group is similar. There is prolonged fever as a criteria. There is evidence of multi-organ dysfunction, at least more than 2 organs involved in the part of the definition criteria. There is lab evidence of hyperinflammation involved and a presumed or confirmed infection by SARS-CoV-2. However, there are still substantial amount of criteria where they differ. For example, as far as the WHO criteria is concerned, they detail the clinical manifestations to quite an extent as opposed to CDC and the UK definition. On the other hand, if you look at the MISC criteria to involve children in the spectrum of MISC, the criteria are extremely broad. And when the criteria are so broad, it may even eventually lead to a type of overdiagnosis in terms of MISC, which is also something that we have witnessed in the ICUs. So there is a bit of a paradox here. However, despite the risk of this overdiagnosis in studies, like ma'am had pointed out previously, the incidence of MISC is still, I would say, uncommon, is not very high. And I mean, you could also argue at the same time that the incidence may be higher if the awareness was more, but we are now getting more and more aware of this entity. One problem I see with all the definitions or the diagnostic criteria that have essentially been laid down in all the different definitions are that all of these have been based on clinical manifestations in children who have more or less a severe disease. So if we use these criteria to diagnose all our MISCs, then the less severe cases, one end of the spectrum, may actually be underdiagnosed and underreported. So this is a concern that I have. In any case, if you look at for today's talk, since we are talking about MISC in particular, we will stick to MISC itself, right? And the criteria for diagnosis of MISC, the age group, as you can see, is less than 21 years of age with a fever of more than 38 degrees centigrade or 100.4 degrees Fahrenheit for 24 hours or more. At least one of the lab results which have to be indicative of inflammation, which includes an increase in CRP, ESR, procal, IL-6, fibrinogen, D-dimer, ferritin, LDH, and increase in neutrophil count or a reduced lymphocyte count, as ma'am mentioned. Lymphopenia is a very striking feature that we have found in many of our MISC cases. In fact, we have also been able to correlate a very high neutrophil to lymphocyte ratio to the severity of the MISC cases that we have seen. And reduced albumin, which is also a striking feature in children with MISC. Majority of them have had slightly lower albumin. Evidence of SARS-CoV-2 infection either by swab testing or on serology or a possible exposure to a COVID-19 case in the past. Now, looking at the epidemiological scenario, there is there is always a likelihood of the child having been exposed to someone in the previous, say, 4 to 6 weeks who had an active COVID-19 infection. So these are the criteria. At the same time, the very important fact which was already been stressed upon is that you have to ensure that other diagnoses are excluded. So there are many acute febrile illnesses or fever with rash syndromes that mimic MISC or which MISC mimics. And those we are used to seeing a lot more in our routine practice and in the ICUs also. We take dengue fever for example, or a rickettsial infection. We know about the overlap of Kawasaki and MISC, which is a love story which is going to go on for a long time now. And many such illnesses, including toxic shock syndrome, etc., which we must rule out because a lot of our tropical infections as well will present with similar features, and some of the lab parameters will even match those of MISC. For instance, a severe dengue with hyperferritinemia. So exclusion of other diagnoses is extremely important. And finally, organ dysfunction, where at least 2 of the following organs are in failure. You either have a circulatory problem, that is the child may land up to you in shock, or you have evidence of conduction abnormalities in the heart. Usually the heart involvement in MISC can be, it can be defined as a pancarditis kind of situation. You can have everything from a pericardial effusion to a myocardial dysfunction, which is becoming more and more prominent. You can have valvular abnormalities, you can have conduction disturbances. And as we all know, they have all, or at least 20 to 30% of them are even prone for coronary artery aneurysms or coronary artery dilatation. So any problems with circulation or in the heart, coagulation abnormalities, GI abnormalities, skin involvement, and respiratory involvement. So any 2 of these with the other criteria should lead you to the suspicion of MISC and possibly push you to evaluate this child for the possibility of MISC. So when essentially do you suspect it? If you look at this picture, all of the manifestations that we talked about or different organ systems that may be involved are described here. Now, essentially, if you the time that PIMS came about, a lot of it was aligned with Kawasaki disease. If you look at the clinical picture that PIMS-TS provides, there's a lot of diagnosis of incomplete KD or complete KD that it leads to if you look at just the PIMS-TS criteria. So the thing is, over the period of the last 1 year, this illness has evolved and it will continue to evolve. And what we are going to see is an entire spectrum of a very mild case of MISC with high-grade fever and minimal organ dysfunction, right to something with multi-organ dysfunction to an HLH, which is involving multiple organ systems. So in this picture, you can see that the presenting manifestations of MISC, apart from a high-grade fever, include other organ involvement, which may include, for instance, neurologically, we see a lot of children coming with headache. We've seen a few children coming with who are encephalopathic, and a couple of them even with seizures. And so these are neurological manifestations. At the same time, myocarditis, coronary aneurysms, hypotension, hypoperfusion, tachycardia are all the CVS related presentations that we see in MISC. Abdominal symptoms, which have been very prominently reported, or GI and neurological symptoms have been fairly prominently reported. So acute onset fever followed by abdominal pain, diarrhea, vomiting, these have been frequently reported in children with MISC as presenting features. These are something that we must look out for because this has been one of the striking features for all the cases that a lot of the cases that we have seen in our unit. At the same time, the presentation which mimics a Kawasaki, like for instance, presence of conjunctivitis, a rash all over the palms and soles and the face, presence of stomatitis, swelling over the hands and feet, or edema of hands and feet. So essentially looking at the criteria of Kawasaki disease. Apart from that, other organ manifestations, including renal manifestations and lung manifestations. Now, lung manifestations have been fairly uncommon in the classical MISCs that we have seen. Majority of them have actually required respiratory support because of shock and cardiovascular dysfunction, and not because of a primary respiratory problem. So when you're looking at children who are coming with fever, and I remember ma'am saying fever of more than 3 days, I think that is a very, very valid point. With fever more than 3 days is when you should maybe start getting worried and look at the possibility of MISC, obviously along with the other diagnosis that we have talked about, or the other diagnosis that I said we should exclude. So if you were to look at it in terms of just an A, B, C, D, E, F, children coming with abdominal pain, blood-tinged eyes, cold extremities, or evidence of a procoagulant or prothrombotic state, cardiac involvement, diarrhea, extreme fatigability, and fever. These are the children in this current epidemiological scenario that you must start thinking about MISC, and side by side look for other causes as well. Now, since there has been a lot of talk about MISC or KD, let me just say that if you look at the comparison of MISC and KD, the age group predominantly for MISC is quite broad. For instance, it basically we are looking at a lot of cases. Yes, we have seen cases below the age of 5 years as well, but predominantly majority of the children are between the ages of 5 to 15 years, as opposed to which Kawasaki disease is basically something which we see in younger children, mostly less than 5 years. Population wise, there is a different incidence of both in similar populations. We know that Kawasaki disease is fairly common in children in South Asia, whereas MISC has rarely been or very less. It has been reported to a very less extent in South Asia, like Japan and China, etc., despite a very high caseload of SARS-CoV-2. So there are, obviously there are genetic, there are genetic implications in this that come into the picture. We know certain genotypes are more prone for KD. So, the evaluation for MISC also will be ongoing, and we might find out, in the future as to which populations are more prone for it. But currently, the incidence of both does differ in similar populations. As far as gastrointestinal and neurological manifestations are concerned, like I said, they're more common in MISC as a presenting feature as opposed to Kawasaki disease. Coronary involvement. Now, coronary involvement has been reported in whatever in literature or MISC literature involving the cardiovascular system. Coronary involvement has been reported up to 25 to 30% of the cases. But over the duration of the last year, that incidence has gone down. So Kawasaki disease has more commonly seen coronary involvement. As opposed to that, presence of myocarditis has been very commonly or routinely seen with MISC as opposed to that in Kawasaki disease. Platelet counts, if you look at the lab parameters, as far as the lab parameters are concerned, platelet counts in MISC, yes, they are decreased, but not to a very severe extent. So we've seen platelet counts ranging from about 80,000 to 1.5 lakh per cubic millimeter. So this is the kind of range that I'm talking about. And majority of the MICs, even the really sick ones, have not had a very severe thrombocytopenia requiring a platelet transfusion or having overt bleeds. So that has helped us to differentiate it from even situations like a severe dengue, where you have a lot of thrombocytopenia, rickettsial fevers, a lot of thrombocytopenia involved, as opposed to this slightly decreased platelet count in MIC. We know that children with Kawasaki disease have a continuously or progressively increasing platelet count, which also tells us about the difference between the two. Other lab parameters, as far as they are concerned, lab parameters indicating organ dysfunction tend to be worse in MIC as opposed to KD, which is indicating the difference in the degree of inflammation, which is supposed to be much worse in MIC. Now, we must remember that some patients with MIC have demographic, clinical, and lab characteristics that will allow their inclusion among KD cases, but a lot of them will differ significantly as well. So this differentiation of MIC and KD will become even more confounded when we have a shock-like scenario involved, because then because Kawasaki disease shock syndrome will present with a lot of these features as well, and they will also present with abdominal pain and encephalopathy, etc. So these are the things we must keep in mind. The thing is, when it comes to management, even the therapies that have been tried in MIC have fairly been aligned with Kawasaki because of the similar presentations on many levels, though the pathogenesis of both remains different. That in itself is an evolving subject, which is not the focus of discussion today. But there lie the differences between MIC and KD. Now, when we evaluate these children, or when we are thinking of a child who's come to us with MIC or supposed MIC, we must remember a few things before we evaluate. We should know the criteria that we are looking at to satisfy the diagnosis of MIC. We must at the same time remember all the possibilities, all the other infections like a severe UTI, a toxic shock syndrome, a sepsis, the tropical infections, which can lead to a similar picture. We must be able to assess the severity, and we must know our limitations. So this whole cascade of MIC has brought about few fundamental questions, and all of them are related to stratification of these patients and to mild, moderate, and severe, and different scoring systems have evolved and are still evolving. The other fundamental questions that have been asked are who we're supposed to treat and who we're supposed to let be, and lastly, what are we supposed to treat them with. So we must be able to answer these questions. We must be able to assess the severity, and we must know the limitations of what we're doing, the limitations of the resources that we have at our disposal, as well as something which is very common in our setting, the constraints, the financial constraints, because the frequent monitoring of these patients with MIC, the ICU admissions, the respiratory support, all the drugs involved, all the investigations involved, all of that can impose a significant financial burden on the parents. So we must remember all of these things while we are treating them, or when we decide to evaluate them. So many algorithms are available online now. Many of the centers, CDC itself, American College of Rheumatology, Italian Group of Rheumatology, they've all come up with their own algorithms to diagnose MIC, and they've all come with two separate tiers of investigations where on initial suspicion only a few set of investigations are done, and if the child looks like he's worsening or he's falling into those investigations positively, then the next set of investigations are done. So, but we must tailor these to our own settings. For instance, here I've mentioned this algorithm, which is from the Italian Society of Pediatric Rheumatology Study Group, where they've talked about presence of fever and more than two organs involved, if and evidence of SARS-CoV-2 exposure. So if on one hand you have no evidence of SARS-CoV exposure, despite which you maintain a clinical suspicion, and if there is no presence of shock or Kawasaki-like manifestations, your suspicion is lowered and you look for other possible causes instead. On the other hand, when you have evidence of SARS-CoV exposure, you look at two steps of labs, which I will show you, and you at the same time maintain a suspicion for possible MIC, and ongoing surveillance is extremely important. The continuous observation of these children is extremely important. At the same time, those with severe organ dysfunction who are admitted to your ICUs and to the hospitals with MISC will also require a lot of ancillary workup, a lot of other workup, which may routinely not be a part of your diagnostic criteria, including imaging of all kinds, etc., based on that particular patient's needs. So, like I said, the investigations there have been divided into two steps. The first step essentially consists of a complete blood count, where the lymphopenia is something which has been stressed upon. If we look at if we get a situation where we are looking at a biocytopenia or a pancytopenia, the possibility of HLH looms large. At the same time, CRP coagulation profile, hyperfibrinogenemia is something that is very common with MISC. We've seen it with a lot of our MISC kids. On the other hand, hypofibrinogenemia should make us a little more conscious towards HLH. At the same time, a basic panel of electrolytes, a liver function screen, a renal function screen, and a blood gas in children who are admitted, especially to the hospital, to look at evidence of ongoing acidosis and high lactates. So this is the first step or first year of investigations. And if you get parameters that are fitting into your diagnostic criteria, and the child seems to be following in the direction of worsening or looking more and more like MISC with the clinical features, then you have to look at further detailed evaluation based on what kind of manifestations you are looking at, where you will look at all the other acute phase reactants. You'll look at procalcitonin and ESR, LDH, all of those things. And children who have cardiac involvement, you'll look at possible high troponin or pro-BNP levels, which will help you to rule out presence of myocarditis. So this is one way of going about evaluating an MISC child, where you have different tiers of investigation. This is a protocol that is suggested by the American College of Rheumatology.
Sorry to disturb, sir. Last 5 minutes, sir. Sorry to disturb.
Yeah. So this is a similar protocol which you will get online based by the American College of Rheumatology, which you can follow. Again, while evaluating your patient, as far as our sick children are concerned, what we do in the ICU is we evaluate them completely with a blood count and all the organ function tests and inflammatory markers. We don't send IL-6 at all in the beginning. Definitely not. Very few patients have we required it for. We look at a detailed organ screening, and like ma'am mentioned, we always rule out different organs that have different causes that can lead to a similar picture. Now, when we look at the management of these patients, I need you to remember a few things before we look at the drugs, and I will take just 5 to 6 minutes more. There is no final consensus on the therapy yet because not enough literature is evolved. We need to support all the systems and monitor degree of inflammation clinically and biochemically. You need to tailor therapy to suit your patient. You need to consider clinical presentation, organ involvement, and lab parameters when choosing biologics. When you're dealing with a case that is refractory to your initial therapy with IVIG and steroids, we must again know our limitations, and lastly, we must follow up closely. So before we actually manage these children, we are often faced with a dilemma about admission or no admission. So children where we are looking at diagnostic evaluation and we get few parameters positively correlating to an MISC situation, even if mild, there are these possible clinical scenarios or even lab parameters that might push us to admit these children. Children who have persistent abnormal vital signs like tachycardia, tachypnea, respiratory distress of any severity that could be attributed to underlying cardiac dysfunction or metabolic acidosis, changes in mental status, including subtle manifestations, evidence of renal injury or hepatic injury, which is evolving, very markedly elevated inflammatory markers, and abnormal ECG or pro-BNP, which will tell you that this child is at risk of cardiac involvement in terms of conduction defects or a myocarditis. Now, apart from this, additional evaluation may also be warranted for those who may present with multi-organ involvement. However, these criteria, as long as these criteria are fulfilled, you might decide to admit the child. Now, when we look at management strategies in MISC, a multidisciplinary approach is often beneficial, especially in critically ill patients. You can have involvement of your cardiologist who will talk to you about coronary artery involvement, who will do bedside echoes for you and tell you about the ejection fraction, left ventricular dysfunction, diastolic dysfunction, all of which are very routinely seen in MISC. you can have involvement of hematology, infectious disease consultants who will help you rule out other possible diagnosis or exclude other possible diagnosis or etiologies which present similarly, and rheumatologists, if available, who will help you or guide you through the use of immunomodulators and biologics. Now, as far as pharmacological therapy in MISC is concerned, one of the chief aspects, and after this, I'll just quickly go through the drugs. One of the chief aspects of therapy is management of shock, which is not different in MISC as opposed to any other child who comes to you with shock. Cardiogenic component of shock is very common in MISC, so we must keep an eye out for that, and bedside echo is very helpful. But remember that a lot of these children present with a distributive kind of shock. So you will need to use fluid therapy. You will need to use vasoactive drugs, including inotropes and pressors, often in combination. You will need respiratory support for shock. You must use an antibiotic until your diagnosis is established. One broad spectrum antibiotic is good enough. Bedside echocardiography will be crucial in monitoring these children with shock, because a lot of them will have left ventricular dysfunction, and lab markers of cardiac function or trends in lab markers of cardiac function will be very, very useful. One point which I want to make, say here, is that consideration of early use of steroid when diagnosis seems likely and the shock is fluid refractory will always prove to be beneficial in your children. And we've had a lot of kids who we have given early steroid in the course of the illness, despite them not being on 2 or 3 inotropes or pressors, and they've responded very well. As far as the drugs concerned, drugs to be given are concerned, they include, IV immunoglobulin is something that has been stated clearly as the first line therapy. Obviously, we have our own limitations when giving IV immunoglobulin because of the costs involved, which are very high. I won't go on to the mechanisms of action, but the dose recommended for IV immunoglobulin, which is now evolving as a standard of care in severe cases at least, is 2 gram per kg as an infusion over 12 hours. But children who have LV dysfunction, we must give about 1 gram per kg per day for 2 days, because they have a tendency to go into fluid overload. At the same time, there are some studies which are talking about second doses of IVIG in cases that are refractory to first dose, where fever has persisted for 24 hours of duration despite the first dose. But large doses of IVIG are risky. I mean, cost-wise, obviously they're not really not feasible, but they're risky because they can lead to hemolytic anemia and further chances with fluid overload. A lot of the protocols or institutional protocols or criteria, the recommendations that are coming in are using IVIG with steroids at a lower dose in severe cases. But the dose range for steroids is going on to between 2 to 30 milligram per kg per day of methylprednisolone. Use of aspirin, again, there has been a lot of talk about use of aspirin. Again, the evidence or experiences vary in different institutions and different protocols. However, what has been said is that use of aspirin in smaller doses, the dose varying from 3 to 5 milligram per kg per day, has been used in various protocols. What we tend to do is that children who are presenting to us with features of Kawasaki or high phenotype or high inflammatory scores, those are the ones where we are using aspirin and anti-inflammatory doses, and once afebrile for a period of 48 hours is when we are coming down to the antiplatelet doses. Now this dose of aspirin is being continued, and the child, as long as the child is being monitored serially for up to 4 to 6 weeks with serial echoes, because these children do require ongoing follow-up. The safety concerns, like I've mentioned over here with aspirin, obviously are the risk with bleeding, especially those with thrombocytopenia. So platelet counts more than 80,000 is something that we must be targeting. Corticosteroid, like I said, methylprednisolone is the steroid that we've been using. The only place that I've read of dexamethasone in MISC is where we are talking about a CNS involvement or an HLH kind of picture, is where dexamethasone 10 milligram per meter square is being used. But doses ranging from 2 to 30 milligram per kg per day have been reported in various institutional protocols. What we do is we used a simple 10 milligram per kg per day for 3 to 5 days in our severe cases, and then switch to oral steroids, which have been continued for 4 to 6 weeks with gradual tapering. At the same time, there have also been recommendations that children who have milder disease, mild to moderate form of disease, can be given lower doses of steroid. Mild disease has also been given 2 mg per kg per day of steroid and then tapered with oral steroid over 4 to 6 weeks. So there has been a lot of, as per the current reviews, 60% of patients receive steroid and up to 50% receive IVIG and steroid. So there is a bit of a shift in balance either way. which has been going on over the last year. For the last 2 minutes, a little bit about the biologics in which the IL-1, IL inhibitors, IL-6 inhibitors, TNF inhibitors are the ones which we are talking about. There's been a lot of talk about Anakinra in the literature that has been published. So Anakinra, we know, is an IL-1 inhibitor, and IL-1 has been implicated in the pathogenesis of MISC to a significant extent. The problem with Anakinra is that it's not available to us currently, so the use is currently out of question. But in refractory MISC, we have been thinking, what we have used in our setting occasionally, on a couple of occasions, we have used tocilizumab, where we have the child has been refractory to IVIG as well as steroids, and IL-6 levels have documented to be high, and we've used tocilizumab fairly successfully, and it's thankfully given us good results. Obviously, there are a lot of safety concerns with that as well, because of risk of hepatotoxicity and thrombocytopenia, neutropenia, and infections, which we are worried about. The dose is, as mentioned, a single dose of 12 milligram per kg in patients less than 30 kg, and 8 milligram per kg in those more than 30 kg is what needs to be given. Last word on anticoagulation. Now, there's a lot of talk about low molecular weight heparin being used in children with MISC. Now, there are very specific criteria laid out for use of low molecular weight heparin, and that doesn't involve only a high D-dimer report. Children who are, say, in the older age group, who are at risk of prothrombotic states or have known already to have thrombotic events, those who have a reduced left ventricular dysfunction, these are the children, or those with coronary artery aneurysms with a Z-score more than 10. These are the ones who we start on low molecular weight heparin, and they are continued often until discharge or until the EF has improved, or even beyond that on outpatient basis if they persist to have coronary artery aneurysms. There is one patient where we have used a KD phenotype patient of MISC, where we have used in a resistant refractory MISC, we have used infliximab because the child was, and infliximab is known to be used in refractory Kawasaki disease. And we had also got good results with that, single dose of 5 milligram per kg. But there is obviously some literature on infliximab in patients who are already on infliximab or on immunological therapy like Crohn's disease or other inflammatory syndromes, who have done well with infliximab therapy. So as far as the outcome is concerned, there is still emerging evidence on prognosis, obviously, which needs time. But however, initial mortality from MISC has shown to be low. Medium-term follow-up at present is fairly encouraging. And though truly long outcomes are unknown, but existing evidence points towards an acute condition with resolution is what we are hoping for. Right? So in conclusion, the ongoing emergence and rapid dissemination of knowledge is very useful for clinicians all around. In 2020, we touched the tip of the iceberg as far as MISC is concerned. Today, we know a little bit more, but the illness is evolving rapidly, and so is the evidence. And I'm sure in the next 3 to 4 years' time, we will be far wiser and be managing these cases much more vigilantly. Thank you.
Thank you very much. Thank you, Dr. Bhakti. Such a nice presentation, making very easier to understand all the complicated these cases and all that. Thank you very much. Now the session is open for the question answer forum. I will invite all the faculties and
Dr. Yevle.
Yeah, good evening, Dr. Deshpande. First of all, my sincere apologies, and I must thank Tanu Singhal for bailing me out of this bad situation. Last 36 hours, I've been really very busy. I have logged in from the hospital, but I was listening to the talks intermittently, and so I thank and my regret and thank you so much, Tanu, for pitching in.
Thank
So,
you,
Deepak,
sir.
shall we
You
start?
have taken such a time. Yes, yes. Thank you, Yevle, sir. In spite of these all things, you have joined. Thank you very much. Deshpande, sir, you can start.
First of all, I should congratulate both of you. Have given fantastic lectures, and we had prepared a lot of questions from our pediatrician group, but most of them seem to be answered. So we have to, because Tanu's presentation was extremely elaborate with all sorts of questions which are likely to come from the pediatrician. They are already answered. So we have to rearrange our questions because most of them are answered. So first of all, my observation is that at least in Pune, the patients who are affected in earlier first wave and second wave, their socioeconomic category is different. Is it same in the Mumbai, or what is the reason? Is the variant knows their economic status, or the first one has first wave they are affected, that's why they're not getting affected, the lower socioeconomic class?
Yeah, it is same here that basically this second wave is affecting more people of the middle class and the upper middle class. And
What is the
because
reason?
probably these people did not get infected in the first wave. They were at home, they took precautions, and the virus was not so infectious. Whereas people who were in the lower socioeconomic status, they all got infected and they got immune. And while there may be a variant virus circulating, still previous infection does seem to offer protection against this variant. Because otherwise we would be seeing a lot of reinfections, which we are not. So
Okay.
that I feel is the same, that these people who were not infected the first time are now infected.
There are some questions in the chat box. Is the CT scoring, that CT scan scoring, not the CT on the RT-PCR, is same for the adults as in pediatrics?
Yeah, it is the same because the software which they use is the same, which elaborates it, which calculates it.
Okay. Then there is one question or more of a suggestion from Dr. Kinikar, madam. She is managing the Sassoon COVID unit. Her observation is basically that there are more of a in second wave there is more of a RT-PCR positive with myocarditis and hypertension, with cytokine markers high in the second wave, and they are responding to IVIG. That is her observation. Many are coming with meningitis. So any take on that?
Yeah, so when you have a child who comes with these kind of manifestations, now first you will have to decide whether this is acute COVID or this is MISC. Because, many patients with MISC will also have this RT-PCR positive. Because they were infected 1 month ago and the RT-PCR is positive. So how are we going to differentiate between the two is a little difficult. But basically, if you have predominant lung involvement, then it means it's acute COVID. Because in MISC, lungs are relatively spared. You don't see the thing. So that is one way. But so if you are thinking this is acute COVID which is causing this problem, then you would offer. But then for all these other manifestations, you would give steroids and IVIG, even if it was acute COVID.
Just
Okay.
interrupting, ma'am. Sorry, the COVID antibodies are negative in that case.
COVID antibodies are negative, so that means this is acute COVID only, because most of the patients with MISC would be antibody positive. And that is why I said that you can have any patient, you have to warn the people who have fever to not only for breathing difficulty, but also other organ dysfunction, because it may, like even in adults, we see that they come with encephalitis or they come with encephalopathy or a GI presentation. The same thing this is. The only thing is that in adults, whenever we saw myocarditis, we saw it in association with respiratory involvement. So they also had GGOs in the CT, they were hypoxic, and then coexistent, they had myocarditis.
Okay.
And at least with whatever experience I have in adults, we have treated these people only with steroids. We've not given IVIG in this setting. When they came with an acute COVID illness with myocarditis, and they seemed to do well with the steroids, they had rapid recovery in the cardiac function.
Madhu, can I make an observation here? One most important thing that all of us must remember is whether that detection of RT-PCR antibody is causally related to the condition that you are saying. Very often, not very often, I would say sometimes it could be just a coincidentally detected positivity. Last 15 days or so, we saw about 7 to 8 patients. Like we had a child who came with fever of 3-4 days duration, and typically with hyperinflammation features, a very high CRP, high ferritin, and the child had both the PCR and antibody positive. This child's grandparents had COVID illness, mild symptomatic COVID illness, about 2 to 3 weeks back. So this child perhaps was had fever for about 4 or 5 days, and there was a dilemma of whether to call it infectious or non-infectious because antibodies had already appeared in the circulation. So that was one thing. We saw a case where the child's RT-PCR was positive. Child had very high fever. Child had all the evidence of hyperinflation, CRP of 400 plus, high ferritin, and this child turned out to be acute pyelonephritis. And we were about to give him IVIG, and there were talks about giving steroids also to this child. His cardiac.
So you are not.
So this was just acute pyelonephritis. We had an 11-year.
You are getting muted, sir.
Yeah, we had an 11-year-old child who came with fever of short duration, was delirious, had altered sensorium, and we did a lumbar puncture. It showed some 300 odd cells, but the CSF blood sugar ratio was not altered. And child didn't, of course, 11-year-old child unlikely to be pyogenic meningitis.
Not audible.
Sorry. So this child, then there were talks about saying that this could be that febrile inflammatory syndrome with where you have we have a rheumatologist with us. He always keeps talking about mass kind of things going on in different organs, liver, kidney, and brain, and whether this was inflammatory syndrome related encephalopathy. This child turned out to be Japanese encephalitis. We sent his antibodies to IAP Pune, and this was a case of Japanese encephalitis. We had a atypical Kawasaki in a very young infant, and her RT-PCR was positive because the whole family was down with COVID. So we really do not know whether it was causally related or just a chance find. We had a patient who presented with a 2-year-old child, presented with fever, irritability, gastrointestinal symptoms, loose motions, high fever. We had sent all the markers. Again, very high CRP, high ferritin. In fact, this child also had altered urine protein creatinine ratio. And the blood culture was Salmonella paratyphi. This child had started showing evidence of mucositis also. And we just treated this child with ceftriaxone. We were about to give her IVIG, thinking that this is quite like a atypical Kawasaki in this. So the point that I'm trying to make is we need to be a little careful whether we are really dealing with febrile inflammatory syndrome or MISC. A lot of usual pediatric illnesses have started appearing again. If you look at the evolution in last 1 year, last February, we were seeing all sorts of pediatric illnesses. The OPDs were full. The practice was as usual. March came the lockdown. Post-March, the pediatric practice was almost brought down to almost 5 to 10% of what it was. The only practice that was going on was immunization and newborn. The obstetric was not affected. And around mid-August to until December, we started seeing cases of MISC. There were several talks, several opinions. At one end, you have febrile inflammatory syndrome, then MISC cases, typical Kawasaki-like or toxic shock-like. And then we evolved over a period of time. And then everything appeared to have disappeared. And we started getting our cases of urinary tract infection, febrile illnesses, acute viral illnesses. And in between, there was an outbreak of acute gastroenteritis with fever, viral diarrhea, sometimes in the month of February. And then came this UK variant with increased transmissibility. All children, febrile children, who were tested either because the parents were positive and the family opted out for testing and they came with the report, or as a policy of testing before admission. The number of febrile children went up, but the positivity also increased. And as Tanu said, this probably that variant which has increased transmissibility and it is affecting more of pediatric population. And today I read somewhere that more than 60% of the samples are showing that double mutation, which again has increased transmissibility. So I mean, one needs to be a little careful while we assign a label of COVID to each and everything just based on the positivity of either RT-PCR or antibody. This is, I thought I must bring to your notice. This is what we have seen. Two distinct things that we have seen in last 6-7 months is we saw 3 or 4 children with perforated appendix, and almost 2 or 3 of them had COVID antibody positivity. We had a child with appendicitis with superior mesenteric vein thrombosis. Whether this prothrombotic state was because of COVID, because her mother had a history of DVT. This child we are going to evaluate again after 3-4 months for protein S, protein C, and the thrombotic state. We had 2 or 3 children with diabetic ketoacidosis. Again, their antibody RT-PCR, one of them had RT-PCR positivity, the other child had COVID antibody positivity. So it's only with time we'll realize whether it is just a chance association or there is causality behind all this. I thought I would make these observations. Tanu would like to know your comments on this. Have you seen similar kind of thing at your end, and even Dr. Bhakti?
No. So I agree that, when you have a sick child at this point in time, you have to, the sick ones, you have to make 3 differentials. One is acute COVID, second is MIS, and third is alternative diagnosis. So these 3 things have to be in your mind in any sick child. And you have to differentiate, you have to do all the investigations to try and bracket them into one of the 3. And we must understand that there's a lot of overlap in all the 3 things, because the inflammatory markers remain high in all the 3 illnesses: severe acute COVID, MIS, and severe bacterial infection. All of them will have high CRP, high IL-6, high D-dimer. And nowadays people think that if D-dimer or IL-6 is high, it means it's COVID or MIS. But remember that D-dimer and IL-6, we were not measuring in bacterial sepsis.
Absolutely.
Those were the conditions where you actually see D-dimer and IL-6 maybe in thousands, unlike in COVID where you see it in 200, 300. So I agree with what Dr. Bhakti, Dr. Vevle said, that you have to differentiate between the 3 illnesses. One more observation which I want to make is that as far as MIS is concerned, steroids seem to do better than IVIG. In fact, there's a randomized controlled trial in UK which has compared IVIG with steroids, because IVIG is very expensive. So there was a French trial, retrospective cohort study, which was published in JAMA, where they compared children with MIS who got only IVIG and who got IVIG with steroids. And they found that those who got IVIG with steroids had better outcomes as compared to those who got IVIG alone. So that is also because, sometimes IVIG is expensive, so you don't know what to do with these patients. So use high dose pulse steroids then in that situation.
Deepak, you want to ask?
One small observation. Anytime this small nursing homes would get patients of febrile inflammatory syndromes, and if the child has myocarditis or tachycardia, tender hepatomegaly, and your rest of the investigations are yet to come, and there is a transfer required to a higher center, and there is a lot of difficulty in getting a bed at such higher centers. It is, there's a strong, this is what I do in my practice, that you must give a dose of steroid after having ruled out your usual infection. That one dose of steroid can really be life-saving to such child who has started showing signs of myocarditis. Do you agree with me, Dr. Bhakti?
Yes, sir. As I mentioned, sir, we've in my slide, when I was talking about shock, like you've pointed out, sir, there is a consideration for using steroids slightly early, even if the child is not really on an inotrope in that situation where you are strongly suspecting MISC and you've ruled out your other positive etiologies. So you, despite the shock, you've not started on inotropes, you've not looked at that catecholamine refractory shock that we know of, but the early use of steroids, and we've seen a lot of children revert. At the same time, I completely agree with what ma'am has also said, that whatever literature is coming through now, use of IVIG with low dose steroids is showing a better outcome as opposed to that of only IVIG. So a lot of these sick cases, like I pointed, the severe ones receive IVIG and steroids. IVIG for us, a major limiting factor, like I said, is the cost. So using sick children where we don't have access to IVIG, using pulse dose steroids is a good idea, and for about 3 to 5 days, then taper it off. And if we can get our hands on any IVIG, then nothing like it.
Deepak, you want to ask?
My next question is to Yevle sir. Sir, any different management for COVID in adolescents, or we can say as a high BMI with obese children?
So my experience is limited to managing only 2 children. One of them was, yes, as Tanu mentioned, those obese, overweight adolescent children who have respiratory involvement and evidence of some oxygen requirement or hypoxia in the form of oxygen requirement, we may have to use remdesivir. We have used remdesivir in 2 children who had pulmonary infiltrate. One of the kids had diabetes, and both the kids were obese, and they showed respiratory involvement with requirement of oxygen. These were the children where remdesivir was used. Otherwise, I don't have much experience. I've hardly used adult-like treatment in any pediatric COVID. Tanu would be able to throw some light on this.
Tanu ma'am?
Yeah, so actually these adolescents, obese adolescents should be treated like adults. Most of them weigh above 40 kg. So you would use the same principles of treatment of these patients. Like I showed that adolescent girls, 2 cases I showed that you would use this.
Any role of inhaled budesonide in early stage?
Yeah, actually, I was just going to that thing, and this is the big thing which has happened now, because there is a publication in Lancet, which I would urge all of you to read. You can just put Lancet and inhaled budesonide, where they found that there was a reduction in the need for hospitalization in patients given this. So this is something to consider, because it was also being proposed right from the beginning that people who are asthmatic or inhalers are not getting severe infection. I still have to read the whole paper. So, and this is a harmless thing to do, because this is not giving early oral steroids which can interfere with viral replication. But this is actually in adults, so I don't know how it extrapolates to children. But one thing I would definitely say, that children who are on inhalers and who are on inhaled steroids, we should not ask them to taper or stop their medications at this time in the pandemic.
How to diagnose a reinfection, as RT-PCR may remain positive for some time from the earlier episode?
So 3 months is used as the cutoff, So if somebody after 3 months of the past infection has a illness which is compatible with COVID, and you do a throat swab and it comes positive, it is most likely a reinfection. However, I must say that we've had some people, who have tested positive even after 4 to 5 months of the first infection with high CT values, especially when their second wave was not on. It was like low season, let's say in January. So we would still not consider these as reinfections. But the definition includes that there should be a 3-month gap. And actually, you should have, a difference in the genome of the first and the second virus. But that is not possible, because even if you send this this isolate for sequencing, the earlier isolate is not archived. So you can't prove that. So, however, if you actually have a patient and you send the isolate for whole genome sequencing, and they find that the virus which is found has the mutations which are in the currently circulating viruses, then you confirm it as a reinfection. In fact, I would encourage that your labs should intimate the local authorities about all those people with confirmed reinfections, so their viral isolates can be sent for sequencing.
Okay. One question now. We are talking of D-dimer and IL-6 levels. What precautions are to be taken by sending it to the lab? If you can elaborate whether they need to be sent on ice or can be sent like that. The values generally change.
So IL-6 has no role to play really. I mean, why we shouldn't be doing IL-6 at all? Because so D-dimers also, but the most important thing is that clotting should not happen, because if you have a patient in whom the blood partially clots, the D-dimer can come high. So that is why if you have a patient where otherwise the patient is stable and their high inflammatory markers are not high, and your D-dimer comes very high, then you should think that there's been an error and repeat it. Dr. Bhakti, would you like to add to that?
Well, I completely agree. As far as IL-6 levels are concerned, we have also not done them routinely at all. In the few patients who have been refractory to our initial therapy with steroids and IVIG. Those are situations where we have managed to document an IL-6 where we have actually considered the use of another biologic, or based on the phenotype, we have decided what to go ahead with it. Those are the situations where we've been divided. We had one child with a Kawasaki disease shock syndrome like situation where he had significant left ventricular dysfunction, all the features of Kawasaki, similar age group, etc. And IVIG had not worked. We had tried steroids. That's when we documented IL-6, but IL-6 was also not elevated, so it didn't help us in any way. And we ended up with a situation where we used infliximab as a part of resistant KD treatment, and he responded beautifully to that. So there is a bit of confusion there in that sense. I mean, we've had situations where we've used tocilizumab in 3 children where IL-6 levels were higher, but we did them only after the initial first 3 to 5 days where we've managed them with our first line therapy with IVIG and steroids, and they've remained refractory. In fact, one of them had even gone on to deteriorate significantly. So those patients did fairly well. We were lucky, I'd say, that they did well and they responded and the illness reverted. But apart from that, we have not really seen any real benefit of routinely sending IL-6 levels.
And also, please remember, IL-6 is not needed for any OPD patient. No patient in the OPD needs IL-6 because the time taken between transportation of the sample and all is a long time. So IL-6 is really needed in critically sick children in the ICU.
Bhakti sir, continuing with this, is it mandatory to have a COVID antibody status as a positive for the diagnosis of MISC? And another along with that, any cross reaction of dengue test with COVID antibody test?
So to answer your first question, if you look at the diagnostic criteria, looking at the current epidemiological scenario and history of any contact with COVID positive patients, even with a negative serology, we might still go on to anticipate the diagnosis of MISC as long as the other criteria are met, and we have successfully excluded other bacterial infections and tropical infections which would present similarly all those scenarios that were just discussed. We may still consider the presence of a multi-system inflammatory syndrome is what I would say. And for the second question, I think there have been reports that have talked about cross-reactivity between dengue antibodies. I think even in the outset of the pandemic last year, I think during April, May, there were reports about cross-reactivity between dengue antibodies and COVID antibodies, if I'm not mistaken.
No, they were not true cross reactions. I just want to add to that. See, many people were coming, they were doing dengue IgM, they were doing dengue IgG. So it's possible that, you have dengue IgM positive because of an infection which you had 1 year ago. So that is not like a real cross reactivity. So that is why, people say that MISC plus dengue coexisting with each other, coming with fever and all that. So it is usually, in the current situation, it is MIS only, and the dengue IgM is a false positive because you have to look at hemo concentration and other things, capillary leak. If those things are not happening, it is most likely MISC.
Any role of Montelukast regarding MISC?
No.
No, sir, we've never used
it. Any role of that inhaled NO that is coming in WhatsApp University? Inhaled NO, that some paper has nasal in NO spray.
Sanitize trial.
Have you gone through it or?
No, it is basically they found that the viral load was reduced, but what it actually happens to the person is not there, as far as I understand, that it reduced the viral load. So maybe it may be of some benefit in reducing transmission. But remember that the virus which had to go down your respiratory tract and attach to the ACE receptors there and enter your body has already happened. So
one question is there, what is the false, is there a false positive antigen test? False positive COVID antigen test?
Not really. Not really. I've just seen one case, where there was a person who had to go and attend a wedding and they did an antigen test which came positive, and then we repeated an RT-PCR and it came negative. So that's very, very unlikely. So in the correct setting, so if the person has clinical features of COVID and your antigen test is positive, the positive predictive value is very high. You should take it.
ivermectin has been mentioned in the AIMS protocol, may be given. That is causing a lot of confusion. So we have specifically mentioned in our TOT also that ivermectin has no role, but AIMS protocol is shown in mild cases may be used.
Yeah, it is causing confusion because recently there is a meta-analysis also which was published, which showed that ivermectin has some role, but it was a preprint. It was not published in a peer-reviewed journal, and all the papers which were included in the meta-analysis were also in preprints. The only paper which has been published in JAMA on the role of ivermectin in mild COVID-19 shows no benefit. So, and also, intuitively also why it would work. And earlier also the studies came out that the dose of ivermectin which you would need in your body to inhibit the SARS-CoV-2 virus is so high that you can't achieve it with this dose of 12 milligrams per day. And the WHO has also cautioned against use of ivermectin. So I think we should not be using ivermectin at all. And we have numerous patients who have received ivermectin and have come to the hospital in dire straits. So, and some people who have got better may have got better just on their own. So I think ivermectin, doxycycline, azithromycin, hydroxychloroquine should not be used, and favipiravir for that matter.
Plasma is also has no role, but it keeps on coming. Plasma.
This is routine practice.
Convalescent plasma is always given. ICMR has taken out it from withdrawn it, but still there are advertisement demand for the plasma.
See, we must understand that this is an illness where we are clutching at straws. We don't have any effective drug for this infection. That is why, everybody, what do we have to offer to people actually, if you see? But what is now being realized is that the positioning of convalescent plasma like remdesivir was wrong. It was given to people after 8 to 9 days of infection when they already had their own antibodies against COVID. So convalescent plasma can be considered as a poor man's monoclonal antibody. Like Regeneron and all, which is used there, you can consider using it in some person who's very early in the illness when they don't have their own antibodies, who are immunocompromised, who are at high risk for progression. But this would be meaning in the day 3 or day 4. By that time, these people don't end up in hospitals. So that is the issue. But all these things are, emotionally driven things. So, if some person will use it and say no it works, like I may say in this meeting that remdesivir works, there are other people who are saying that don't remdesivir doesn't work, and there was a statement in the paper that it's not a life-saving drug and all that. So perspectives differ.
So
but all I would say is that people should not go to great extent to procure convalescent plasma or something. That's not needed.
My next
I think
question is
a
to
lot of
Yole
questions
sir.
have been answered. Yole sir is not there, I think, right now. So just a last couple of questions to Tanu ma'am. Practical questions from pediatricians. Ki healthcare workers who are feeding, for example, can they get vaccinated, because there is no clear guidelines regarding that?
Yes, we are advising them to get vaccinated because the WHO says they can take the vaccine.
Second question is ki children who are tested positive, what about the routine vaccination? Should it be deferred for some time? What is the guideline?
No, there is no need to defer the vaccines. Once they recover from the acute illness, you can give them their vaccines, including the live vaccines, unless they have received IVIG. If they've received IVIG for MIS, then the live vaccines have to be delayed by 9 months. If they have received steroids for more than a week or so, then you can delay the live vaccines by 1 month.
Otherwise, for 14 days only.
That 14 days cutoff, yeah. And that is mainly applicable for, of course, it will take 14 days for them to recover. And also that is the gap between COVID-19 vaccination and other vaccines. So if somebody, adults, who are taking the COVID-19 vaccine, then they should take their flu or other vaccines 2 weeks after the COVID vaccination.
Last question from my side. Mother is often started on favipiravir because she's positive. So can that mother breastfeed the child?
It is contraindicated in breastfeeding and pregnant women. So pregnant women, definitely, it's a highly teratogenic drug. And breastfeeding women also, I have told there's no benefit. It's not a life-saving drug, etc. So if they are taking favipiravir, if you go by the drug indications, I would tell them to stop breastfeeding the child or stop the drug.
last 2-3 questions only. Can 2 different vaccines should we get? Suppose we have get a Covishield first and no availability of that. So should we go for Covaxin?
No, definitely not, because the app will allow you to only take 2 doses of the vaccine. So you should wait till Covishield becomes available.
Any use of any extra dose of Pfizer or Moderna, will it be beneficial after completing of 2 doses? Current
It may be
considering all the
beneficial.
new variants,
It
new
may be
mutants.
beneficial because it may be beneficial, but these vaccines have not come up into our country. So, but
Whenever it
many
will,
countries,
whenever it will be
whenever it
available.
will come, yeah, it may be useful. Yes.
Role of Covaxin against the variant is variant.
So there is some data to say that it works against the UK variant because of lab data. So when they took the sera from people who had vaccinated with Covaxin and they showed it to this, they tested the UK variant, it worked. And we must remember that the UK variant is not such a bad variant, apart from the fact that it is highly transmissible. It usually is covered by most vaccines, including Covishield. So Covaxin would cover it.
Any role of thymoquinine?
No.
Last question to
I think we'll have a
Bhakti.
last question now.
Last to Bhakti sir. Any evidence of use of NSAIDs over paracetamol, especially with coagulopathy as a part of disease, especially in MICs?
Only situations where in MIC we've used, like I talked about aspirin. We've used it in situations where we are looking at Kawasaki phenotype, or we're looking at presence of coronary artery aneurysms where the inflammation is extremely high or coronary artery dilatation is present. That's where we are looking at using aspirin, and we initially tend to use it in anti-inflammatory doses which are higher, and then after 48 hours of afebrile period is when we move towards a antiplatelet dose, which is continued for a longer duration for at least 4 to 6 weeks while the child is monitored serially with lab parameters of including inflammatory markers as well as echocardiographic evaluation, which is ongoing. Apart from that, no other NSAIDs in particular that we would be discussing. As far as paracetamol is concerned, basically it's just treatment for fever and nothing else over there to mention.
What about indigenous mutant evading RT-PCR?
No data so far. But I feel that one of the reasons why the PCR tests are not picking up is maybe because of the burden on the lab. Lots and lots of samples, and the cost has come down so much. The government has
Very
put the
true.
cost down, so I don't know how much primer they are using, how much other things they are using.
Okay. Thank you very much, ma'am. Such a nice presentation, and you have cleared all the doubts which are very much needed in current situation. Thank you once again. Thank you, Bhakti sir, also. Thank you very much. Thank you, DigiShield, for providing such a platform. And thank you all delegates. In spite of such a late night, everyone is attending very actively. Thank you, Dr. Anand Deshpande sir. Thank you, Pramod Kulkarni sir. Thank you, Sanjay Nathu sir. Thank you, Dr. Parag Gaikwad sir. Thank you, all of you. Thank you.
Tanu madam, thank you for patiently taking all the questions in spite of being such a late hour. Thanks a lot, ma'am.
Thank you, ma'am.
Hope to come to Pune soon. Yeah.
That variant lecture was very, very fantastic.
Thank you. Thank you.
It cleared all the doubts. Really, it cleared all the doubts. Now it's easy to practice with this all information.
But it seems that the COVID will continue for n number of years. Looking at the,
I don't think so. I mean,
important
maybe it is wishful thinking.
Important take-home message: unnecessarily don't admit, don't use remdesivir, and don't do RT-PCR in such a situation currently.
Absolutely. Most of the patients, children that we are seeing, the parents just need reassurance. The children just need paracetamol. That's it. Yeah.
Thank you. I declared today's topic is over. Thank you everyone again. Thank you very much.
Thank you, sir.
Thank you, Bhakti. Thank you, ma'am.
Bhakti, thank you.
Thank you.
Piyush, I think we can wind up.
All right, sir.
Thank you, Deepak. Thank you, Deshpande sir.
Thank you. Thank you, all of you.
Thank you, Kulkarni sir. आहात का सर?
आहे बाबा. थँक्यू सो मच. छान झालं, एकदम छान झालं. व्हेरी नाईस.
येस सर. चालेल, भेटूयात सर, बोलूयात. चलो
Yes.
दीपक.
चलो बाय. गुड नाईट.
चलो, सी यू. गुड नाईट.